Great. Thank you so much, Cameron. And thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Specialized Aging Support for Individuals with Intellectual and Developmental Differences. The National Alzheimer's and Dementia Resource Center webinar series is sponsored by the Administration for Community Living. Before we start, Chris Stockton of the Administration for Community Living will provide us with a brief welcome. Chris?
Afternoon, everybody. Thank you so much for joining and taking the time to join us today for this webinar. And thank you, Eunice Howard and Abby Such, for coming and gracing us with this educational experience. Back to you, Sarah.
Great. Thank you, Chris, so much. So as you heard, today's presenters are Abby Such and Eunice Howard. Abby Such is the director of the adult day programs at the ARC Jacksonville and spearheaded the launching of their specialized aging support program. Abby oversees 3 different day programs provided through the ARC, all supporting adults with intellectual and developmental differences. She received her bachelor's degree from University of Tennessee and her master's of occupational therapy from University of St. Augustine. We also have with us today Eunice Howard, who is the receptionist and accounts payable for the ARC Jacksonville. She has worked for the ARC Jacksonville for close to 5 years and was awarded the Face of the ARC Award in 2023. Eunice is also the sister and longtime advocate of her brother, Ed, who has Down syndrome and is a participant in the ARC's Specialized Aging Support Program. At this time, I'll turn our presentation over to Abby Such to begin.
Thank you all. We are excited to be here today. So this project was supported and funded through the Administration for Community Living. We're very grateful for their funding to be able to do all of the different things that we're going to share today. So thank you to ACL. Some of our objectives that we're going to cover in today's webinar include, hopefully you'll walk away understanding and being able to describe the characteristics and challenges that are associated with intellectual and developmental differences and see how those intersect with Alzheimer's disease and related dementias. So when I refer to ADRD. And then also we hope that you can explore different strategies to maybe design and implement some programs similar to what we're doing here at the ARC Jacksonville. The ARC Jacksonville as a whole, our mission is to serve and advocate for individuals with intellectual and developmental differences to achieve their full potential to be able to participate in community life. Our vision is to always enrich their communities and to have quality options on how they live, learn, work, and play. So the specialized aging support is one program that's within the ARC Jacksonville. We have over 16 different innovative programs that we offer here. And then the specific initiatives that we focus on with this program are to establish and create a more dementia-capable workforce. So that includes providing trainings not only for the people within our organization, but also for the Northeast Florida area. And it's actually carried across statewide now. So we try to increase everyone's knowledge on the prevalence of dementia within the IDD population. And then also just educating on those different aging factors that we need to look at within our population. Our second initiative is to focus on providing services to those who are living with or at high risk of dementia. So we'll get into what those terms are in a couple of slides. And then our last initiative is really focusing on increasing support and education for caregivers to navigate the difficult road that comes with aging and dementia. And that includes family caregivers, but also paid support professionals that we focus on. When I refer to IDD during this presentation, at the ARC Jacksonville, we say intellectual or developmental differences, and that is to focus on their strengths and abilities that are unique to somebody who has an IDD. So that includes just a few of these different diagnoses that we see under here, including Down syndrome, cerebral palsy, autism. So when I refer to IDD, that's what I'm talking about. Some of the inevitable risk factors for dementia that we see are age. Although dementia is not a normal part of aging, it is very common as people increase through age. We also look at family history, and something a lot of people don't realize, even within our IDD community, is that Down syndrome is actually one of the very inevitable risk factors for developing dementia at some point in their life. Just a few statistics to share. 90% of people living with Down syndrome will develop some form of dementia by the age of 65, and there is an increasing rate as they age through each decade of their life after age 40. Alzheimer's is currently the #1 leading cause of death in people with Down syndrome, and that is because it is closely related to the 21st chromosome that carries a gene closely related to the genetic risk factor of Alzheimer's. So since they have 3 copies of that 21st chromosome, that's what research has shown is the close correlation. Then all of our other IDD population who have a diagnosis aside from Down syndrome, so it could be just general intellectual difference, cerebral palsy, any of those other things, they definitely develop at an accelerated rate, but not quite as rapid as those who have Down syndrome. Although they do generally have an earlier and more rapid progression than the rest of the population. They have about a 50% higher rate of developing ADRD than the typical population does. So all of those words I like to show with this graph because it really shows into picture kind of the rate that people, so the typical population without an intellectual or developmental difference, kind of, it's this darker line. And so you can see the progression kind of starts to spike in the mid 70s to 80s and really ramps up around 90 to about 30%. Whereas people with Down syndrome, you can see it as early as in their 30s. It really starts to take a spike, though, in their 50s, 60s. And then the general IDD population is the dotted line, so that's in between. So most adults with IDD are at a slightly higher risk, but Down syndrome is at a significantly higher risk. So these are the rates that we have been seeing and were shown in this study. Now, what we look at is the key difference between dementia and IDD is the loss of a person's typical level of functioning, or what we like to refer to as their baseline. So a lot of times physicians or doctors may say, Ed's not tying his shoes. Well, it's because he has Down syndrome. But if Ed used to live by himself, tied his shoes every day, made, breakfast for himself every day, and all of a sudden that change has occurred, that is what we start seeing. So when we say that loss of a person's typical baseline, we have to see what their baseline was for the majority of their life, or what I like to describe as the peak of their life. So while characteristics of dementia and IDD might look the same side by side, it's that difference in baseline that we really look at. Then we explored why did the ARC see this need to apply for this ACL grant and to start this initiative. So there's a lot of age requirements for senior-based services and programs. So a lot of different services in the community will see a minimum age of 65 or 60 to be able to be included in these senior service programs. When we have that earlier onset of people aging closer to 40 and 50, maybe they're around 60, but generally our folks don't meet those age-based requirements. And it excludes them for those who have those earlier onset of symptoms. We also saw a limited education and training on the IDD population. So Eunice will share a little bit about how maybe medical professionals weren't quite listening to what was going on because they said, well, if he has an intellectual difference, maybe that's what's causing this decline in function. So there is a limited education and training. And then that leads to a little bit resistance in accepting those with an IDD of, oh, I don't know if we can serve your population here. So it could be medical professionals, it could be those who are running those senior-based age programs, whether it be a day program, an assisted living facility, anything of that kind of nature. And then there's a significant difference in age within certain programs when they even do try to integrate those with an IDD. And so that difference in age comes into factor if we say refer to someone to an adult day program, but it's all 90-year-olds who are in wheelchairs who aren't very active. If you take a 40-year-old who has Down syndrome and is still active and just needs a little bit more assistance, the blend leads to more limited social engagement. So these are all things that we were seeing as an organization that we wanted to address. So now I'm very excited to share, the microphone today with Eunice Howard, who is a dear colleague of mine. She has seen the decline with her brother, and she's going to share a little bit about him and what it's like in the program. So thank you again, Eunice, for joining us. If you'll just share a little bit first about Ed's level of independence, kind of before all of the changes started happening.
He was able to do quite a few things. Even my parents were able to leave him at home by himself just for a little brief time, and he would be fine. He could make his lunches, he could take showers by himself and stuff like that.
Definitely. And then what are some of the more significant changes that started coming about when you started noticing things were changing?
He could not remember birthdays because he was always remembering everybody's birthday, what day it was on, the month and the date. That was my first indication because he kept forgetting that. And then he would forget about different things that we had talked about before. And that was the start of it.
Definitely. And then I know when I came into the picture, Ed lives in one of the ARC Jacksonville's community homes with staff support. And one of the staff members said how he used to always go get the mail from the mailbox. And all of a sudden he went down to the end of the driveway and kind of got confused.
Right.
And so when we first launched the idea of this program, and we were looking at the people that we already serve who could benefit from this program, that was one of the key signs of saying, I think Ed is starting to show a little bit of decline. So something that he used to do totally independently, now he needed a little bit more assistance with.
Yes.
And then we'll get into, the difference that SAS has made in his life. But what was his personality like before he started attending SAS after those changes started occurring?
Before he was grumpy, and more emotional. He was just mainly grumpy, and he didn't like doing everything, but that's how he was before SAS.
Yeah. And then just another personality trait I know we had talked about was his witty comments, right?
Yeah, he used to be so witty. It runs in our family. We would just be a little sassy with each other, and he would be able to pop up a little comment here and there and join in the fun and just laugh with us all the time with everything, with my older brother, my younger sister, and my nieces and nephews, but now he doesn't do that anymore.
Yeah. So just those subtle changes that we've definitely seen, but we'll get into what SAS has done for Ed and Eunice and her family. But thanks for sharing all of that, Eunice.
Thank you.
So when we talk about eligibility for our program, so when we received this grant money and we started assessing who in the community, whether it be within the ARC Jacksonville or within the ARC Jacksonville or within the Jacksonville community, who could we serve? So we have two different kinds of groups that we look at. We look at people who are at high risk. So it's everyone before they're starting to show signs of that cognitive decline. And because we see an increase after each decade with people with Down syndrome after age 40, we came to the agreement that people with Down syndrome above the age of 30, since we know that the brain changes 10 years prior to a diagnosis, was a good starting point. In addition to being 30 years old, there could be people who are incredibly active at 30 years old. We look at the rate of their obesity according to BMI, and then do they have a lack of exercise or a history of poor nutrition, since those are all factors that can lead to dementia diagnoses. Everyone else who does not have Down syndrome but has a different intellectual or developmental difference diagnosis, we look at over the age of 50. So those are the two categories for our high risk group. Then those who are living with, initially we said living with signs of dementia or living with a dementia diagnosis, but we realized a lot of people were getting missed in that diagnosis process. So now we've adjusted that to say 3 or more signs of cognitive decline, including memory loss being one of them. So it can't just be that behaviors are escalating or, incontinence may be starting. It has to be that they have 3 or more cognitive decline, including memory, because people are also aging. And while we are an aging program and trying to help with a graceful aging process, we're really looking at that memory loss. So then the intake process, when we received our ACL grant, we went through lots of different flow charts of how is it going to work as we intake people. And so we look at kind of the category of placement for them. Are they living alone or are they living with a caregiver? We have an independent living community with 120 residents. So we consider that living alone because they're not living somewhere that's staffed 24/7. We also look at people who are just living in the community in general, living on their own, maybe with someone stopping by to check in on them. Then we see if they're living with a caregiver, that could be a family member, that could be a community group home, some sort of assisted living facility. And then are they living with dementia or, living with signs of cognitive decline or living at high risk? After we decide kind of which category they fit in, because that determines what days they're attending our program, they're able to come for a tour of our day program center. We sign a service agreement, and then we do the early detection screen for dementia, which is a tool provided by the NTG. And it's really just a screening tool of where were they once functioning versus where are they now functioning. So I talk a lot about baseline when people are onboarding, and kind of what Eunice was sharing earlier is he used to be witty. Now all of a sudden he's not saying those comments quite as much. He used to walk to the mailbox on his own. Now he needs redirection and someone kind of walking with him. So those are things that we're looking at instead of all of those difficult tests that a physician may do in a doctor's office that say start at 100 and count backwards by 7 or draw the face on a clock. So we want to look at our client's baseline versus what the typical population's baseline is to detect that change. So after we do all of that, then they're officially enrolled in our program. And I'm an occupational therapist by trade. And so we do a functional OT assessment on them just to see exactly where are they performing in all of these different tasks. And then if they are living with those signs of cognitive decline, we'll go into their homes and perform a safety evaluation within their environment to make sure there's no tripping hazards, that lighting's adequate, there's no cause for concern. So part of our day program, when we're actually providing those services for those who are living with or at high risk, then we really were very intentional with developing this curriculum. So we looked at all of the modifiable risk factors. A few slides ago, we talked about age, family, and the fact that you have Down syndrome are, non-modifiable. We can't change any of that. However, there are risk factors that we can modify to hopefully either delay the onset or minimize the impact that dementia is actually performing. So we look at cardiovascular health, physical inactivity. So how often are they getting up and moving for at least 30 minutes a day? Limited education. A lot of times folks with IDD have been limited in knowledge about their own rights and choices. There's decreased social engagement because maybe they've always been put into a special education classroom or steered into a certain direction. Maybe there's social isolation. So we look at that. We look at depression and diabetes, and most recently at a recent conference, we learned about all of the impacts of hearing impairment. So can we address any of those things through our program? And the answer was yes. These are things that we can address through a very tailored curriculum. So we look at cognitive stimulation. So every morning they come in and they engage in something that wakes up their brain, whether that be puzzles, a game of bingo. When we first opened, we had coffee first thing in the morning and, talked about current events that were going on in the world, looking at newspaper articles, watching news clips. And now that we had coffee for the first week, there is no going back. So we have coffee every single day now. But that's part of their cognitive stimulation, and it does wake them up. And if we didn't have it, I don't know if our brains would wake up. My brain doesn't wake up in the morning when I don't have coffee. So cognitive stimulation is that first thing. I always joke, it's kind of like that first thing in school when you we're always lucky to have math in the morning because that's when your brain is really starting to turn on and working at its best instead of after lunch. So after cognitive stimulation, we move into a different room and do exercise. So that could be anything from chair yoga to going for a walk outside. It could be some sort of Tai Chi movements. Sometimes we have big exercise ball and they'll do kickboxing with them. So we have a lot of different programs focused on exercise. We then move into either music or life skills. And so that is, depending on the day that they come, we alternate between life skills or music class. We have musical guests that come in and will play instruments. Sometimes it may be kind of karaoke that they sing, or, you know, the little egg shaker instruments. Then we move into life skills, which is anything, talking about anything related to life. So that could be hygiene in the bathroom, hygiene with getting ready in the mornings. How often should we be washing our clothes? Because we want our folks to engage in those purposeful life skills all throughout their lifespan, whatever is meaningful and provides purpose to their life. So then we move into nutrition, which is where they make a healthy snack, and it could be anything from a smoothie to learning about portion control sizes. So I'd say that's a pretty popular portion of the day. They all enjoy nutrition. And then we move into creative expression to kind of wind down. After we've done all of those things, it's something that we can have one example, one medium, but it's great to see how everybody's turns out so differently. And then the end of the day, we end with reminiscence and recollection. So this is kind of the different layout of the day. That reminiscence and recollection, when we first launched the program, I noticed was kind of our dull time of the day. People started falling asleep. They were ready for lunch. They weren't super engaged. So now we always ensure there's a multi-sensory component of it. So it could be scarves. And we prompt with some sort of question that could be, tell us about your favorite family vacation that you went on, or share a memory that you had in school. And we try to go with the theme. So it could be, tell us your favorite holiday memory. And it could be someone said they received a bike for, you know, the holidays one year. So we'll have scarves in our hand and we'll say, okay, wave your hand if you also received a bike. So we're always trying to engage in some sort of sensory component, some sort of physical component, while also diving into that long-term memory. So just jumping back and forth between those two slides, but we really looked at what can we modify. So through all these different activities, we're increasing their social engagement because they're attending the center. We're improving their physical activity, which is then going to improve their cardiovascular health. We're looking at healthy nutrition options, which is also going to improve their overall health and hopefully reduce the risk of diabetes. So all of these things are reducing the risk of depression. So we're educating them throughout the day on all of these different skills. So this slide wasn't really meant for you to read or to dive into. If you're interested in learning more about our curriculum, I'm happy. My contact information is at the end of all of this. But this is an example of what we wanted. So I'm an occupational therapist. We enjoy coming up with different groups that we can lead, and we focus on the purpose of why are we doing it. So every single one of our groups has a description. But while I'm not able to always implement the groups every day, I want our guys to get the same thing. So our staff is now able to take all of my thoughts and thoughts that have been now poured into from occupational therapy students, from some of our other interns, from other staff, and we're able to have now a step-by-step of exactly what can they do during this activity. So this is a matching activity that has to do with hygiene. There's physical, sensory components that are always incorporated into it. So this is an example, and this is what they have for each activity of their day. So they have a cognitive stimulation curriculum for the day. Then they have exercise, nutrition, life skills, etc. So this is just an example of what we utilize, and it's all printed out in a huge binder, and they go week by week now. So we have 4 12-week curricula that we utilize. Okay, and back to Unison Ed. So this is Ed's, just an example of him engaging in the different components of our curriculum. So Eunice, just tell us kind of a little bit about Ed's mood. You said he was grumpy. That was your big thing before he started SAS. But kind of just share with us what he's like now after he's been engaged in SAS.
Oh, I can tell every single day that he goes to SAS, he is in a much better mood. He loves being there. He's happier. He kind of remembers what's going on for the most part, I think, because you keep the curriculum the same every day, which is good, and he loves it there. He loves the music. That's his favorite part.
Yes. He was like always a big music fan though, right?
Yes, yeah, always,
Of
always.
Elvis.
We have always sung together since we were kids, always.
Yeah. No, it's funny to hear that he's grumpy because when he's at SAS, I mean, you can tell in these pictures, he is always smiling.
Yeah.
So he definitely, these are just some examples of exactly what I was saying. So some days for exercise, we might have weights in range of motion, and Ed always says how strong he is, and so he'll pick up his 2-pound weights and show us how strong he is. And then arts and crafts, of course, we're painting very frequently. It's funny this is green because he normally does Jaguars colors.
Yes, yeah, he does. And we always,
Um,
with the workout and the weights, we always tell him he's got Popeye arms.
Yeah, he definitely is. It's funny because these are all different days, but he definitely has similar outfits on in all of them because he's
Oh,
such a
yeah. He loves the Jags.
yeah. So you can see life skills could be something as simple as decorating a Christmas tree. This is in our sensory room, which I'll show a picture of a little bit later on. He doesn't normally go in the sensory room, but he happened to be in there this day. But then this is his nutrition down here where he's making a yogurt parfait. So he definitely enjoys the program, I think.
Oh, he does so much. So I'm so glad he's part of that.
Yes. So this is, when we say the center, we opened up a center for our specialized aging support program. And I just wanted to show a few of the photos that we did. This used to be an escape room that we kind of renovated. And so these are the exercise balls I was talking about where they do kickboxing. They have hula hoops, but they're never, moving their waist. They're more so using them as stretching activities. Sometimes our exercise may be outdoor fun and games, and so when it's not scorching hot or too cold, when it's the perfect temperature outside, we'll go out and do Connect Four and cornhole and different things outside. And then we have our kitchen where we, do our different nutrition activities. This is our sensory room. So this is the swing that Ed was kind of in earlier, and he, a lot of people go in here, and we track how they go in. Are they agitated? Are they disengaged? And then how do they leave? Our biggest thing we're looking for is, do they go re-engage in the current activity that's going on throughout the day? And then this is our functional living room. So sometimes our sensory room can be too exciting for people. There's a lot going on. There's a lot of sounds. There's a lot of sights. And so our functional living room is the second kind of calm down space, but it's also really practical if we're practicing, someone just received a new walker, how can we navigate around an actual living space? Or if we're having those tough conversations with family, it's a nice space to land in there. So there's a lot of different purposes for our living room. Something else that we do is engage in our caregiver education nights. So we host these caregiver education nights about every other month. Eunice has attended one, or a couple of them, but it's really to provide a community for our caregivers who are all facing these different challenges, with their loved ones. So all of those cognitive challenges that we're seeing, maybe a change in personality, but we always bring in some sort of expert in the field. So this photo, the top photo I have here is just our City of Jacksonville Emergency Preparedness Division. So we have kind of a program that caregivers can enroll in case their loved one were to elope. We go ahead and get all of the information. What are their favorite places to go? Do they like to go to the movies? Do they like to go to the park? So that what's their height, what's their weight, their eye color, so that before a tragic incident happens, we already have it. So that was just an example of kind of an expert in the field coming to visit. We also always give a handout for families and caregivers that come. So this is another example. where they, one of our students created a whole curriculum to go along with this. But this is there was a flower pot and they could paint. So that was kind of the first thing a caregiver could do with their loved one as an arts and crafts activity. Then we provided soil and plant seeds, so then they could plant something as a different activity. And then it was to grow basil, so we provided different recipes that they could utilize the basil for. So there's always some sort of hands-on activity because we know all of the benefits of engaging in hands-on activities. We also provide different resources, whether it be through different associations, and provide dinner and snacks for the caregivers for attending. We did start this monthly and found that it ended up being more of a burden for caregivers to try to make it monthly, so we switched to an every other month model. Then when we get into kind of the training that we provide for anyone who's engaged in the program. So volunteers and students come into the program, they all take, this was actually something I found on the NADRC website, and it was called Living with IDD and Dementia, Meeting a Person Where They Are. So I think it's 6 micro learning videos, less than 10 minutes each. And I just thought it was a great baseline for students, volunteers, staff to all kind of understand what's going on in someone who has dementia, who also has an IDD. Then we created our IDD and Dementia 101 training, which is really a lot of material packed into about an hour and a half training. And so depending on, you know, how long we have and how many questions we have and how many examples I can give, this was something that I had created to really hone in on what I thought was most important for people coming into our center to learn about. So we actually provided this Dementia 101 training for caregivers, our first caregiver education night. We also provide it for nursing students, medical students, anyone who is in the IDD population providing services can receive this training. So we're grateful we've trained over 600 people at this point on that specific training. So volunteers and students take that one. And then the Alzheimer's Association courses, we started with the Essentials program, but that was a Florida grant that we received where we could take it for free, and that grant actually came to an end. So now they take these different video trainings. So I think it's a couple hours of training. So we want them to walk into our doors prepared. So we always say, these are trainings that we need you to do before you even come on your first day. And the response is very good with what students say they gain from these trainings. The staff training then, it kind of goes up in a tiered level. So I thought this was just a visual that I could show. So everyone takes that Living with IDD and Dementia, those 6 micro-learning videos. Then that IDD Dementia 101 and Alzheimer's trainings. Then our staff, so our ARC Jacksonville staff takes that NTG EDSD training. So that's learning how to use that screening tool so that after people have been here for a certain amount of time, they can then perform this screening tool on other people. We then have a behavior symptom management training that we provide for internal staff to really hone in on how to manage those difficult dementia-related behaviors. And then, so that's across the ARC Jacksonville as a whole. All 150 of our staff would take all of those trainings. But then that top layer, that NTG training, or we've also added the Positive Approach to Care by Tipa Snow. Those 2 trainings are for people who work directly within our program every day. A couple of the barriers that we faced within our program is transportation. Jacksonville is just large in geographic size, so transportation tends to always be a barrier that we're facing. We only have so many providers that can help transport people to the center. So a lot of times when people want to enroll, it's because, and one of the big barriers we hear is transportation. We also have caregiver challenges, just as working with caregivers who may be aging, potentially showing signs of dementia themselves, fear of the future of what's going on. So a lot of resistance can come from caregivers. We also have, we provide Skills to Care, which is a program that we can help caregivers navigate those specific challenges, but a lot of times caregivers within the IDD population have been lifelong caregivers. So these small challenges that are coming, or big challenges that are coming, may be nothing compared to what they have done. So we have a little bit of a hard time enrolling for that Skills to Care program. Also targeting those living with dementia who are living alone. So that is one of our category areas. However, if they have an intellectual or developmental difference and they also have dementia, they are likely not living alone. So we don't have many that fit into that category. And then also, again, home-based interventions for the sheer geographical size of Jacksonville is difficult to manage. I was just the only OT on staff. We just hired a second OT on staff, and we have a third in a different area. So we're hoping the home-based interventions can improve with time, but these are just some of the barriers that were inevitably going to come. Some of our outcomes were really exciting to see as we created this presentation, and really just timelines with the timeline of the grant. We're into year 3, but we didn't start, so we're going to hopefully have an extension of our period. But anyways, we're nearing towards the end. We're over halfway with implementation of this program. And so we have something called the lifestyle change tool. And we have had an increase in people exercising at least 30 minutes per day prior to entering the program. They said on average, about 2 days a week, they were exercising for 30 minutes a day. Whereas now people are responding at least 5 days a week. So we've seen an increase in exercise, whether that be at the program, outside the program, but regardless, they're exercising more, which is a good outcome. Overall socialization has increased by over a day. So people said that they engaged with others about 5 days a week. Now they're engaging more towards 6, almost 7 days a week. And then engaging in cognitive stimulation activities. So we ask, whether that be puzzles, bingo, board games, any kind of mind games that they might do. And so that has increased from 3 days to 5 days a week. So we are seeing an increase in engagement and in their lifestyle since the start of their program. Then when it comes to training, we look at our IDD and Dementia 101 training, and we always do a pre-test and a post-test. So pre-training, only 75% of people understood the importance of accepting reality when it comes to communicating with someone with dementia. So when I say accepting reality, that's, if someone says, my mom is coming to pick me up, and we know either their mom has passed away, or their mom doesn't live here, or their mom just for whatever reason is not picking them up. Instead of saying, no, she's not picking them up, we might steer them in the direction of saying, tell me about your mom. What time, what do you guys like to do together? Where do you like to go together? So we're accepting their reality instead of fighting them to be back in our reality. So that's a big portion of our training. And so the 75% of understanding pre-test increases to 90% based on that training. So that was a good outcome of that. Our sensory room was interesting to look at. 85% of our clients who use the room are in our living with dementia category. And so we see that there's benefits for people who are in our high risk category, but most of our living with crew engages in those. And then 52% of the people who enter because they are agitated or anxious with what's going on in the environment, but then 95% leave because they feel calm and regulated. And then caregivers report overall that there's improved mood and increased engagement. As Eunice shared earlier, she can always tell the days that Ed goes to SAS. SAS is our nickname for our specialized aging support program. And so she can tell, and we receive that from a lot of caregivers. Oh, now they want to make smoothies at home. Now they want to go out and go for a walk when they come back. Now they want to go so they can see their friends. So we are seeing these increased moods overall. We had one caregiver who said the client that she worked with always did color by number, coloring books before he engaged in the program. And then once he finished, when the dementia started occurring, he stopped doing those color by number books. After about 2 months of engaging, she said, you'll never believe this, He came home and asked for his color by number books, and now he does it every day again. So it's those small things that we receive from caregivers that we know this program is making a difference in their lives. And it's nice to see all of the, numbers that go along with it. But hearing those caregiver reports, we know that this program has been impactful for families. So these are just a couple of our outputs. Like I said, we've trained over 600 individuals on IDD and Dementia 101. We have 4 full 12-week curricula developed. Volunteers are a huge part of our program. So we have almost 3,000 hours, and this was taken in mid-November. So I'm sure by now we're probably at about 3,000, maybe not quite, just shy of 3,000, with over 52 volunteers who have started since last year. And then just some of our expansion and sustainability. We have expanded. We started only open 4 days a week, and we saw an increased need for people to come 5 days a week. So Mondays and Wednesdays are generally our high risk category. That's how we started. Although now we have a handful of people who do attend 5 days a week. So Mondays and Wednesdays were our high risk originally. Tuesday, Thursday was our living with dementia category. And then Fridays were kind of our, let's reevaluate and see what we need to improve for next week. But in April of this year, so we launched in September of last year, come April, we had so many caregivers saying, I think they would benefit from 1 more day a week. Is there any chance you're going to open on Fridays? So we saw the need. And we say Fridays are semi-structured, self-directed. So they don't go through the hard, I was going to say harsh. It's not a harsh curriculum. It's just a very intensive curriculum where they're doing things all throughout the day. Whereas Fridays are a little bit more laid back. They have options of what they want to do. So sometimes we'll lay out board games on every different table, and they can pick what they want to go engage in. They can either choose to engage with, an animal therapy dog, or they can watch, a movie or something in a different room. So, and they can have more time to in and out the sensory room, go on a recumbent bikes. They can do what they want to do on Fridays. We also have collaboration with other day programs since the start of the program. So I now oversee 3 of our different day programs, which allows me to see different clients that may benefit from coming to SAS. We also have an increased training. Originally, we were just going to train our folks here at the ARC Jacksonville. Our staff was going to be the most equipped staff in the Northeast Florida area. But now we actually increased to training different medical schools, different professionals, whether that be rehabilitation students, nursing students, different IDD providers. So as far as sustainability comes, we have our med waiver is our state funding that's provided through the Medicaid waiver. So we're looking at billing into that program to be able to sustain adult day training or life skills development programs. We're continuing to seek different grant opportunities and funding through hospital systems and other local foundations. We're grateful that the community is definitely very supportive of this program. And then Medicare funding, like I said, we hired an additional occupational therapist who is now going to be able to provide Medicare funding. So I think I'm right on time here for our questions.
Thank you so much, Abby. I am working. There we go. Video was a little delayed. We really appreciate your presentation, and we have a lot of questions that came in, so we'll start getting those asked from you to you. If you wouldn't mind scrolling to that last slide with the blue background that I put in there. Some people have asked how the program is funded. This is funded through the Administration for Community Living. You can find out more information about the next cycle of grant projects if you go to grants.gov. If you have questions for NADRC related to the webinars, you can grab our email address right there, nadrc-webinars@rti.org. And with that, I will start with some of the questions that have come in. We'll start with some questions that came in about the progression of dementia or Alzheimer's disease in people living with Down syndrome or another IDD. A few people were asking, is this a sudden change? Is it slowly progressing? Is there a typical pattern? if that's something you could comment on, that would be helpful, Abby. And then Eunice, if you want to talk a little bit about your specific experience, that would be great too.
Okay.
So typically what I've seen since we started the program is a couple different signs. Obviously that change in baseline, but also big things that we need to look at is if someone with Down syndrome all of a sudden is losing weight later on in life. It could be that there's medication changes, or we're modifying diet, but we've noticed that a lot of people who were living on their own with Down syndrome forgot to eat snacks, forgot to eat breakfast or lunch, and didn't have a caregiver coming until dinner. And so we saw somebody lose 80 pounds in about 9 months. So that was a huge red flag that there is something going on here. We also had someone who was living alone within our independent living community who was knocking on people's doors in the middle of the night. And we thought it was a strange behavior, but that paired with weight loss, paired with a little bit of confusion, all of a sudden, all of these puzzle pieces we had to put together to realize the big picture was he's actually showing signs of dementia. So those are just a couple of the things. Eunice, if you want to share what you saw more with Ed.
They were kind of gradual, and as he got older, they've escalated a little bit quicker than at the first part. So he has lost a lot of weight, but that's part of it's due to the group home giving him a correct diet where he doesn't have access to a lot of sodas and junk food like he did when he was living with my parents, and then me for a year, because we still had a son living at home who liked to, snack a lot, but he was healthy himself. So yeah, the weight loss is a big sign.
Also choking. That's something else. When we see not necessarily that they're choking so much, but if they're coughing a lot more when they are eating and drinking, we notice that being one of the first signs that people will see. Maybe their food needs to be cut a little bit smaller. They're not chewing quite as well.
Mm-hmm. I agree.
Great, thank you for responding to that question. Abby, there were a few questions about the OT assessments in particular. Are there any specific OT assessments that you're using?
So we call it a comprehensive functional OT assessment. So I've just developed my own OT assessment where I look at all of the different factors in their life. So we may use a couple standardized assessment, the timed up and go, just to assess balance. That's really the only formalized assessment, because as I've worked in this field now, I've come to find that there is no perfect assessment for an adult with IDD. So I look at just a basic cognition screening. I kind of modified what's called the MOCA, the Montreal Cognitive Assessment. And so I've made our own version of that I now perform on each individual, but I really had to come up with our own version because the perfect one didn't exist for us. So I've tweaked it enough now. So if they're interested, I can show my email, and they're welcome. I'm happy to email it to people to see.
Yeah, feel free to go back to your thank you slide there. That'd be great. Thank you. So those of you who are asking for specific resources, I've tried to respond to as many as possible with Abby's email, but here it is on the screen for you. You can jot it down. Okay. A lot of people are very impressed with the number of volunteers you have. Can you talk a little bit about how you recruit for volunteers?
Yes. So a big portion of our volunteers comes from affiliations with different schools. So we have, I want to say we had 12 before I started, and then I've added 10 since we launched the program. So we have about 22 different school affiliations, whether that be with nursing students, occupational therapy students, OTA students, any kind of we have one, our program coordinator was wonderful. She came from the University of North Florida. She started as a student and she majored in disability studies. So she started, so those school affiliations are definitely the bulk of who our volunteers are. And so the student volunteer hours. And then the others of them, we have board members who recommend different volunteers who come into us. So we have another very lovely volunteer who comes in. And it's great because if we have multiple volunteers, they can focus one-on-one with those people who need a bit more direct attention, but don't have a one-on-one companion with them all the times. But school affiliations are definitely a big portion. And then we send out with our development team and our advocacy team flyers on how people can get involved, whether that be hosting a party for us or coming in and leading a creative expression art activity or our music activities. So we try to hone in on what people are interested in. Our animal therapy volunteer, she's great. She brings her dog in once a week or every other week. So we get volunteers from a lot of different places.
Great, thank you so much. Eunice, there's a question for you, and Abby, I'll ask you to follow up when Eunice is done. Someone's asking if you ever were able to get an official diagnosis for Ed as a family and how you went about that process. And then there's a few questions that have come in as well about, if you are, how you address that with families, where do you send them? So Eunice, if you wouldn't mind commenting, and then Abby, if you could chime in after, that would be great.
Okay. Actually, it was the community home manager. She takes Edward to his doctor's appointments, and through all her diligent efforts, she took him to get the actual diagnosis. And yeah, she's incredible. I don't know what I'd do without her. Families need the help, but I think he got it, was it just this year, last year?
Last year.
Yeah.
And he had been showing signs for years, right?
Yes, he
Yeah.
did. The big one, I think, was going to the mailbox and not remembering how to get back inside the house. So
Definitely. So yeah, it can be a very challenging process. I mean, people could be like Ed and show signs for years and not receive a diagnosis. So it's really advocacy and persistency on caregivers, whether it be family or paid caregivers. But that NTG EDSD screening tool is really it's not for a doctor to fill out. It is for someone to fill out who knows that individual very well. And then when they can compare how they used to be to how they are today. And it can be, I love it because it has 4 different check marks that you can mark for so many different domains. And it can be, they once needed help, they never needed help cutting their food and now they're choking, so now they need assistance. Or they used to tie their shoes, but now they need reminders. They used to, put shoes on the right feet. So I would say that tool is very helpful. Also, people in the medical profession, I feel like they want to hear from someone outside of the caregiver, because caregivers will go over, they'll go to any length to help the individual. But because I'm a medical professional as an OT, I feel like when I sign my name and they see this assessment and I've explained A to Z of what has happened, a lot of times neurologists and different physicians will be more accepting to move that process along, to say they need a diagnosis. And a lot of times we'll say they can't get services that they need without a diagnosis. So we've had good luck with that.
Great, thank you so much. Can you talk a little bit about the age range you see in the clients, and what's maybe the youngest age you've seen come through that's of a person showing signs of dementia?
Yes, we had somebody, the program had not started yet, but somebody was showing signs around age 38. And that's about the youngest that we've seen signs start to come. Luckily, the program started when he had shown signs and they had made accommodations and kept him going until about age 40. And then we launched the program. So the youngest admission was age 40, but he had been showing signs for about 2 years at that point, losing keys, getting lost, losing phone and keys a lot. So age 40 is the youngest that we've seen. And then people go up to age. I mean, we have someone who is in our, who's living with signs, who doesn't have Down syndrome, just a different IDD diagnosis. And he's 78, I believe. So, 38 to 78, wide range there. But I'd say generally speaking, mid 40s to early 50s is when we see the primary signs of diagnosis.
Great, thank you. Can you talk a little bit about when, you talked a lot about the curriculum and the schedule of the day, but in terms of when people arrive at the day center, do you provide them with, their activities for the day? How do they get oriented to what's happening for that full day that they're at the day center?
I'm going to slide back to that slide. So we actually, I'm a big fan as an OT, or just me in general. I always joke with my mom, I was born to be a teacher, but I went into occupational therapy instead. But I love visuals. I think visuals are key to so much success. People understand what's going on with visuals. And so we printed out these schedules and laminated them so that we can write in activities that we're doing every single day. So if the first activity of the day is, a family feud game activity, we can, and some people may write, some may just look at the, icons and know what's coming throughout the day, but they know that sequence of progression. And Eunice mentioned it, but we have a routine. So we don't switch up, exercise first thing or, arts and crafts first thing in the morning. We go in this routine every single day. So I feel like we all engage in routines every single day. You probably do the same thing every single time you wake up out of bed. You go through that same routine throughout your morning. So people thrive on routine. So we print these, we laminate them, they can write on them. We have a few people who live with their families, but maybe a driver takes them to and from the day center, and their families will say she has dementia. She doesn't remember what she did when she got home. So we then fill this out for the family every day and send it home so they can say, how was the animal therapy dog that came in? Did a musical guest come in and sings? And that triggers her to remember what happened. So we utilize this a lot.
Wonderful. Thank you so much. I think we can get one more question answered. Abby, there was a question about, what are the key skills that you see staff really need to move from maybe serving just an IDD population to serving an IDD population showing signs with dementia?
Definitely that accepting reality piece. I think a lot of times, even when our staff start, you can say, someone will say, there's a snake in the room. And instead of saying, no, there's not, we always check. We laugh because we live in Florida, so there really might be a snake somewhere that just happened to get inside. But we'll say, show me where it is, and they'll point. And so we've really worked on staff across the group homes, across our staff training, and in everywhere. We'll say, instead of saying no, there's not a snake, show me the snake, let me get that snake outside. So even just getting an empty box and pretending like the snake's in it and throwing it outside. So that's a lot of things. And I laugh now because we have 2 direct support professionals we call aging care specialists that work within our program, and they come up with the best reasonings of jumping onto somebody's train of thought. So it's, and I find myself even sometimes being like, it's okay, like, don't worry about the snake. And now they'll come up with these good stories to play onto people's reality. So I'd say that's been a learning curve. And we always joke, you have to laugh or else you'd just be sitting there spinning your head all day long. But that's been a big learning curve that I think has helped, is just learning how to manage those very, paranoid behaviors that come about with dementia.
Great. Thank you so much. We didn't get to all the questions, but thank you everyone for participating today. We got to as many as we could. And thank you so much, Abby and Eunice. Your presentations were fabulous and shared so much wonderful information with our participants, both the personal and the professional. So thank you so much. I want to let everyone know that our next webinar is January 28th, 2025. Where we're going to have a panel discussion focused on how life experience as a caregiver can inform one's career in dementia services and supports. It'll be quite different from what we've done in the past, where we have panelists and a moderator. So we hope that you'll join us. Keep an eye out in your email for information on that webinar. And if you have questions, you can contact our team at NADRC-webinars@rti.org, and Abby's email is on the screen now. So thank you everyone again, and we hope that you will join us sometime again soon. Take care.
Thank you.
Thank you.